Good afternoon, everyone, and I would also like to extend the thanks to colleagues from MSF, as well as the SMIR for co-hosting this interesting event and for having me here today. So today I would like to take a bit of a broader perspective, and I will be exploring the health and humanitarian consequences of restrictive border policies. And I will be doing so by drawing on the lens of the ethical dilemmas to which our MSF colleagues in the field are confronted on a daily basis. So by doing so, I hope to explore the impossible choices that arise in settings where policy, and in this case, we're talking about restrictive migration policies, inflict physical and psychological suffering upon individuals who are on the move. But first, a very quick word just for background on MSF's work in migration settings. So MSF has a long history of responding to the needs of displaced peoples. We can think since the 1970s to the response to displaced people from Vietnam, Cambodia, all the way to today, to responding to the needs of displaced people in South Sudan, in the Democratic Republic of Congo, in situations of internal displacement. And these, I think, are situations that often are conjured up when we think of MSF's work internationally. In the last decade, however, more than responding to the inherent medical needs of displaced people, MSF has been responding to the consequences of restrictive border policies on the health and well-being of people who are on the move. This has especially been the case in Europe, where we have observed migration policies and practices being increasingly predicated on violence, containment, and exclusion, with oftentimes devastating consequences on those who are displaced. From the external borders of Greece to settings of externalized migration control in Libya and Serbia, all the way to the shores of Calais, MSF is now present across several settings where it responds to the consequences of European migration policies. It's important to note that migration itself does not have an automatically negative consequence on the health of people who are on the move. However, all along migration routes and at borders, what we are seeing and documenting through our operations on the ground are the negative consequences of policies on people. Most people that we see all along migration routes and at borders report to us having experienced one or more traumatic events along their journey. This includes instances of torture, forms of violence and ill treatment, different forms of detention, both formal and informal detention, multiple cases of pushbacks, oftentimes violent pushbacks, as well as instances of being stranded at sea, in the forest, and in the desert, oftentimes without humanitarian assistance, no food, and without clean water. This also includes experiences of structural violence and exclusion on arrival. These experiences of violence along migration routes are not accidental. They're often the direct result of policies designed to contain, deter, and to exclude. So with migration policies understood as an important social determinant of the health of people who are migrating across borders, we, as MSF, a medical humanitarian organization, have committed ourselves to being present in places where the health and well-being of people migrating has the most been put at risk. In practice, for us, this has meant being operationally present in a growing number of European settings where migration policies are at their most restrictive manifestation. It is also in these settings, however, that our position as a medical humanitarian organization, which is rooted in long-standing principles of impartiality, independence, and neutrality, as well as rooted in medical ethics, that it has been the most challenged. So this has given rise to impossible dilemmas for our colleagues in the field, and it is precisely these dilemmas that I would like for us to reflect on today. So in the next few minutes, I'll be walking you through and us through 4 of these dilemmas that we are dealing with today. The first, across Europe, we are witnessing increasingly punitive and coercive measures being enforced on individuals seeking protection. The most illustrative of this are the various forms of formal and informal detention which are proliferating across Europe, as well as at its peripheries, oftentimes funded by the EU. The use of various forms of detention continues to expand today, despite the now mounting evidence of the harmful effects of such measures on the health and well-being of migrants. As our more than 20 years of operational experience in such settings, as well as academic research suggests, detention can exacerbate anxiety, depression, PTSD. It can lead to self-harm, as well as morbidities that are often directly linked to the conditions of detention. So from the EU-funded close control access centers of Greece to the violent detention camps of Libya, MSF's medical activities in closed settings often directly palliate the harm caused by the condition of detention themselves. In Greece, the structures that we see here, we provide mental health support to people whose state of anxiety and distress are born of or exacerbated by the restriction on their mobility and the conditions in which they are forced to live. Over the years, in the EU-funded Greek hotspot, we have responded to a disturbing number of adults and children with suicidal ideations, for example. Meanwhile, in Libya's detention centers, MSF has been responding to skin and respiratory infections caused by unhygienic conditions and severe overcrowding. We have also been treating the physical wounds and pain which our patients report to us having been caused by violence and ill treatment committed in those very same centers. So the provision of mental health support to new arrivals in Lesbos and the treatment of morbidities caused by violent and unsanitary conditions in Libya are but two examples of treating the harmful effects of detention on people. In other words, these are but two examples of treating the consequences or the symptoms of avoidable harm. This raises the clear question of the moral trade-offs of operating in spaces where people's ailments stem directly from their detention conditions. On the one hand, by treating the physical and psychological consequences of closed settings, we are, importantly, making the detention conditions more bearable for our patients. And in that sense, we're responding to their most immediate needs. On the other hand, by improving the conditions of detention for our patients, are we not also, we must question, making the moral cost of this detention easier to bear for policymakers and detention authorities? Are we not also inadvertently becoming part of the very same system that is the source of harm in the first place? Every day, our medical personnel are having to navigate these impossible dilemmas, questioning whether to respond to people's immediate health needs at the risk of reinforcing the system, and oftentimes reaching the limits of meaningful humanitarian and medical action. Worryingly, with such forms of detention proliferating across the borders of Europe today, and importantly, this is being condoned at the EU level through current negotiations around the EU Pact, we, as well as other medical humanitarian actors, are bound to be confronted with a growing number of such scenarios. Second, the right to seek asylum has never been as restricted as it is today. Although in theory, it is every person's right to be able to ask for international protection. In practice, we have seen various tactics being put in place which have the effect of limiting this universal right to seek asylum. One such way we have seen the universality of asylum restricted has been what we can understand or we can call the vulnerabilization of asylum, through which the determination of vulnerability has become a necessary precondition to access asylum procedures in the first place. And here, medical actors have been called upon to play a key role in this determination. Most emblematic of this was with COVID-19 related travel restrictions and border closures, where we saw public health measures seized upon as a means to restrict access to territory and asylum for the vast majority of individuals arriving and in need. Italy, for example, implemented a two-tiered system for people landing by boat in Lampedusa. On the one hand, those who were flagged as vulnerable upon landing were referred to centers on land in order to quarantine. And then on the other, those who were crudely categorized as not vulnerable were sent to offshore quarantine ships, which were moored off the coast of Italy, where they were often kept for prolonged periods in worrying conditions. The conditions on the ship mirrored that of a detention center, although with limited presence of health actors and reports of severe distress, suicide attempts, and a number of deaths on board. This scenario plays out in other ways to this day as well. In Greece, for example, the majority of applicants for international protection, in particular those who are deemed as having passed through a safe third country, are channeled through asylum procedures with lower safeguards, where almost everyone face a high likelihood of rejection in the first instance from international protection. In contrast, those who are recognized as vulnerable, according to categorizations that are put in place by the authorities, are granted access to what should otherwise be normal procedures. They're granted access to a more protective form of asylum procedures. Medical practitioners in this setting can therefore play a crucial role in attesting to the medical and psychological vulnerability of their patients. This means that their patients, on an individual basis, have access to a more protective form of procedure. This, too, we see has raised and continues to raise very serious ethical dilemmas for our colleagues in the field, as well as other medical practitioners. By advocating for our patients on the basis of individualized needs and vulnerabilities, we can ensure that our patients have the care and protection they need. At the same time, however, we're also potentially reinforcing a system which denies the rights to access protection for the vast majority of people, and oftentimes with potentially serious consequences on their health and their well-being too. In Greece and Italy, for example, uncertainty in obtaining legal status is considered a precipitating and aggravating factor to people's mental health and distress, as observed by our teams in both countries. In the case of Italy's quarantine ship, people who were not considered vulnerable were kept in detention-like conditions with harmful consequences on their mental health. And this is just one area where, by acting in the best interest of individual patients, health actors are also at risk of being manipulated by exclusionary border management systems. These, in the end, can induce forms of harm to the health and well-being of the vast majority of those who are not considered part of the vulnerable few. Third, in Poland, our teams at the border with Belarus are having to make the impossible decision of referring people in need to hospital, knowing that this might result in them being pushed back to Belarus. What happens, or rather what risks happening to an individual after they are referred to hospital, has become an important determinant around decision-making during our interventions at the Polish-Belarusian border. So in this densely forested area of the Polish-Belarusian border, we often meet people with very serious medical needs, oftentimes sustained as a result of falling off the 5.5 high meter wall, which is also razor wired, or as a result of having had to hide in the forest for days out of fear of being pushed back, and oftentimes with no food or clean water. This perverse situation has been enabled in Poland by domestic legislation enacted in 2021 during the so-called border crisis, which now allows border guards to return individuals who have been apprehended during or after having crossed the border directly back to Belarus. So against this remote and inhospitable landscape, where individuals are in fear of being pushed back to Belarus, where some have reported having experienced violence and ill treatment, we see people who have very high medical needs, and they only accept to be referred to hospital in the most extreme cases when there is no other option. When the emergency services are called in this setting, it is the border guards who are immediately alerted. It is the border guards who decide whether or not the person should be sent to hospital. In some cases, individuals are directly pushed back to Belarus at this point, despite their dire medical condition, and this as a result of having called for help. In other cases, individuals are referred to hospital, are able to receive appropriate medical care, but are directly returned to Belarus following their discharge from hospital. So with hospital referrals often resulting in the direct pushback or detention of discharged patients, emergency services, ambulances, and hospitals are at risk of becoming nodes within a broader link of violence. Medical actors have at times been put in a position where they're at risk of becoming a link towards further ill treatment. As a result, individuals in need of urgent medical attention are often reluctant to be referred to hospital. Many prefer to remain hidden in the forest, at times at great cost to their health. One person encountered in the forest, for example, reported to our team preferring to die in the forest than return to Belarus. That individuals may be placed at risk of return to Belarus simply by virtue of seeking needed medical care has serious ripple effects on their access to care, as well as MSF's operations in the forest. These need to be carefully navigated on a daily basis. Unsurprisingly, this places a disproportionately heavy responsibility on our medical team, who are forced to carry the burden of what may happen after a patient is referred to the hospital. Unfortunately, however, this situation risks becoming only one example where healthcare workers are at risk of becoming a link within a broader chain of harmful practices. My last case. Finally, what happens when punitive border policies turn against medical and humanitarian practitioners themselves? Worryingly, this is what we have been observing over the last decade in Europe, where the universal duty to act towards those in need has increasingly been put into question when those people in need are migrants. The ethical duty to act and respond to urgent need has, in recent years, been put on public trial. Individuals who extend assistance and support to migrants continue to be put at risk of sanctions, which includes criminal charges and administrative penalties for helping people in need. For some actors today, the risk of criminalization, as well as the burden of administrative restrictions, has made delivering needed assistance too costly and nearly impracticable. On the Greek island of Lesbos, for example, we have over the years witnessed almost all independent humanitarian actors forced off the island. Some people are currently facing charges for having provided humanitarian assistance to people arriving on the island. As a result, MSF is today one of the few independent medical actors providing assistance on Lesbos, despite the rise in new arrivals and the rise in needs. Trends of criminalization and crippling administrative requirements imposed on civil society are pervasive across Europe, however. This includes Italy, Poland, the Central Mediterranean, where our teams attempt to provide assistance in the face of mounting costs and risks. But of course, it is the people in need themselves who are forced to bear the brunt of this. It is making it more difficult for them to access needed medical care when and where it is needed. This past year, Italy, for instance, has imposed stringent requirements on civilian search and rescue vessels, including on MSF's Geo Barents ship. This has had the effect of decreasing the overall capacity in search and rescue, and unsurprisingly, this has also been the deadliest year in the Mediterranean. What this means is that the humanitarian medical actors who are able to remain operational under such circumstances are forced to navigate increasingly hostile and risky environments. This has given rise to troubling dilemmas, especially in places where we deliver assistance to those having newly arrived at European borders. In such places, our medical teams are having to exercise forms of caution and restraint that would be unfamiliar to most medical practitioners. For example, could taking a phone call from a relative in another country to help locate a person in urgent need result in criminal charges for human smuggling? Could hiring an ambulance to ensure that persons in need can actually reach the hospital without being pushed back be criminally sanctioned? Could providing warm clothes and a blanket, what is strictly necessary, or beyond what is strictly necessary from a medical perspective, to new arrivals be subject to prosecution for abetting illegal migration? These are some of the unimaginable scenarios that our teams are having to navigate across Europe today, in a context where anti-smuggling legislation and regulations have been turned against humanitarian actors who help those in need. Unsurprisingly, the risk of criminalization weighs heavily on our colleagues in the field, which imposes an impossible burden upon those who are merely exercising their duty to respond to people in need. So to conclude, borders and the policies that defend them have become the central cause of suffering for many people today. At the same time, this has also given rise to impossible dilemmas for our medical teams who on the ground continue to dedicate themselves to alleviating the suffering. This begs the question, how should we, as humanitarian and medical professionals, respond to the harmful consequences of these policies and practices? As MSF, as well as with many other medical humanitarian practitioners, this begins, most importantly, by directly responding to the suffering on the ground through the provision of assistance and medical care to those most in need. In practice, this means adopting a multidisciplinary approach which addresses the health needs, of course, but also the social needs of individuals. This also means taking an approach that remains sensitive to the political and social determinants that shape health and well-being in migration settings. But we have also seen that this is not always enough. As we have seen now, with our work marred in ethical dilemmas, medical practitioners can and should play a key role in challenging, based on the medical evidence available, the policies that present a risk to people's well-being. We can and should play a role in advocating for the right to health of all to be upheld, and this ideally within a broader framework of solidarity and humanity. And with that, I look forward to your thoughts and reflections on this during the discussion, and thank you.
Very much, Chloe. You can stay.
I can stay. Okay.
Thank you very much. Quite a hard-hitting, gloomy picture, but I think very clear with a lot of examples. I have one quick question before you can return to your seat. We have the next speaker. But as was mentioned a few times, also in the introductory speeches, MSF has been assisting people on the move for as long as we exist, and we're doing it all over the world. Is there anything that sticks out for you from a medical humanitarian perspective about what makes it so special, the situation in Europe as a European organization?
It's a good question. I think there's both change and continuity. What we see is that oftentimes, if I can say, harmful policies borrow from each other. So we see, for example, a lot of what's being put in place today mirrors policies that have been put in place, for example, in Australia with offshore processing, for many years already. So in fact, we're seeing trends being borrowed and implemented in the European context, which have existed in other places for some time already. So I think there is a huge amount of continuity when it comes to the European setting. But what we see today is really a consolidation of these practices being accelerated. So especially at EU level through the negotiations, which you may have heard about, of the EU Pact on Migration and Asylum, we're seeing some of these practices which from our operational perspective we view as having a negative consequence on people's health and well-being. We see them now being negotiated and institutionalized potentially through regulation. So we're seeing it having a ripple effect that is quite far-reaching, in fact, today. So quite worrying trend.
Thank you so much, Chloe.
Great, thank you.